Welcome everyone to the Sign IGOT Pelvic and Acetabulum webinar. We're just going to allow some time for people to join the webinar. While you are joining the webinar, we're going to launch a poll, which you can take to tell us about where you're from and your experience with pelvic and acetabular surgery. I think we're going to get started now, so we're going to share these polling results with you just so you can see where everyone's calling in from. So it looks like we have people calling in from all over the world, mostly from Asia and Africa. Thank you all for calling in. Just in terms of the experience with pelvic and acetabular training, it looks like the majority of people joining the call have no formal training in pelvic and acetabular surgery, so that's great. This will be a good introductory course. In terms of experience and how often people are treating pelvic and acetabular fractures, it looks like the majority are treating 1 to 5 per year, so a low number at this point. So again, I think this will be a nice course for you, but we do have a variety of experience and that people are seeing. And then in terms of C-arm, it sounds like about half always have access to C-arm and half either sometimes or never have access to C-arm. So I think this will be one of the goals of this webinar is to talk about some of the challenges and how to overcome those challenges of doing pelvic and acetabular surgery without C-arm. So we're going to go ahead and begin the webinar. We'll start off with an introduction from Dr. Lou Zirkle from Sign.
Thank you for coming to listen to and view the pelvic and acetabular webinar run in association between Sign and IGOT. This webinar is directed toward those surgeons who do occasional pelvic and acetabular surgery. They may not have C-arms and they don't have pre-contoured plates, which means they have to be excellent surgeons. And we see the results, and they are. The speakers tonight will be Sami Hailu and Gelata Tasima, who run the only pelvic and acetabular fellowship in Africa. They do a great job. Another speaker will be Sam Morshed, who's a professor at UCSF and also an expert in pelvic and acetabular fractures. It is moderated and organized by David Shearer, who's the vice president of the Sign board, and we're very pleased that Dave is working so hard to provide instruction for surgeons around the world.
Thank you, Dr. Zirkle, for the introduction. This is the planned schedule for the webinar today. We're going to have 3 main sections. The first 2 will be didactic lectures by Drs. Gelata Tasema and Sami Hailu from Black Lion Hospital in Ethiopia. The first will be on pelvic ring injuries and the second on acetabular fractures. And then we've created some original surgical approach videos here in San Francisco that Dr. Sam Morshed will share with you on the Coker langenbach and ilioinguinal approaches. After each session, we'll have a question and answer session, which will try to address all of your questions. So if you can please put any questions that you have in the Q&A on Zoom, we'll try to address those. You'll also be able to comment and upvote questions that you might share, so please take advantage of that Q&A function. We're going to be recording the webinar in its entirety. And that webinar material will be available online, both through the IGOT portal and through the Sign Hub. So igotportal.org and the Sign Hub that I know many of you are familiar with. We'll also have the full videos of the surgical approaches available on the IGOT portal. We're going to begin with the first didactic lecture by Dr. Gelata Tasema from Ethiopia on pelvic ring injuries.
Hello everyone, my name is Gelata Tasema, working in Ethiopia, Addis Ababa. Good morning, good afternoon, everywhere in the world with different time zone. First of all, I would like to say thank you, Science Fracture Care International and Igots Smart course organizers for this good opportunity to give our experience, what is done in Ethiopia. Hope it will help for all of us in working in difficult situations. So my topic is on pelvic ring fixation in the absence of CR. So I will discuss on introduction, anatomy of the pelvis, bone model, and our hand. Pelvic ring injury, the mechanism is high energy, blunt trauma, and mortality is very high. In acute settings, like 3 to 15%. If it is open, more than 50%. And unless they are treated properly, the mortality and morbidity is increased than the other fracture patterns. Hemorrhage is a leading cause. So I will not deal on how to tackle the emergency pelvic ring fixation. Rather, I will discuss on techniques in the OR in stabilized patients. So the difficulty in working in a resource limiter center is the first thing is you are the only person looking at the patient, and the patient is begging for your help. In the absence of proper training and in the absence of appropriate material in the OR, that's very difficult, and you are you're teaching like don't do harm is affect your psychology, and it creates more anxiety on you. But there is a possibility to manage even though you don't have a proper training and you don't have a proper CR in the OR. So the first thing what you have to have in the pelvis is you need to have a proper material, especially pelvic sets. Because the pelvic is different. It's not like similar to fixation of the forearm or the tibia, because it is a three-dimensional structure. The neurovascular structure is at risk for injury. So you need to have a proper clamp, a proper soft tissue protectors. And another thing is anatomy. You have to know properly the anatomy, the arteries, veins, nerves, and how to tackle this and how to protect them during your surgery. So if you understand well this, the approach may not be difficult. So the approach may be discussed in a few minutes later. So the first thing what you have in the OR when you think of pelvic ring injury is bone saw bone model, sorry. So your saw bone model, I hope you will have a CT scan in every of your hospitals. So you have to reconstruct a 3D model of your CT scan so that you will have a good understanding. For this, I recommend you to have a free X-ray viewer. It's called Radiant viewer or DICOM. That will be a good thing for your pelvic fixations. So how to use a pelvic model once you reconstruct on your CT, then back to your model. So look at it in different direction. In which place should I put my retractor, and in what direction I put my screws. So that's very important. And you have to also call somebody, especially when you start, you may be confused inside, so that you can call your runner to bring the pelvic model inside the OR so that you can see where you are. So it will guide you easily. And it's also important to analyze after you finish your surgery, see the pelvic model again. Where was your screw? Where is your retractors? So that you will have a good understanding for future surgery too. So in the absence of the C-arm, your hand is very important. You have to coordinate your brain and your hand, and you have to look the pelvic model in mind. So your hand will help you as a guide. Sometimes it will help also to estimate the screw links, and it protects the soft tissue. So I will show you how to fix this type of fixations in the absence of the C-arm. So this is a Simpson's plating technique. So the first thing is you have to open your pelvis anteriorly so that you can put your Homan on each side of the pubic tubercle, and then you reduce your clamp. Once you reduce the clinically the anterior symphysis, the next step is plating. Plating, it could be by using Simsys plates if you have. If not, you can use recon plates of 6 or 8, 7, 8 hole plates. So the thing is a way of your trajectory of screws. So you put your hand, look, my hand is just posterior to the pelvic symphysis, so that I am palpating. First of all, I protect the bladder. You can apply, you can put also the malleable retractor, and you put your hand so that you can palpate the pelvis, so that you think you are drilling anterior to your hand, so that you are in a safe corridor, okay? So the pubic bone is like here, anteriorly it is a wider and thicker place. So aim to have a strong and longer screws. So the first drilling is like a bit deviated lateral and a bit anterior. There is some differences in male and female. In female, a bit the pubic rami, the body is a bit laterally projected, but in male a bit vertical, so that you palpate with your finger as far as you can reach, and you drill it in this fashion. That is the first one. The second screw, you may do a bit medial side, so that you can lock or recross your screws. So these two screws are, most of the time, it's more than 50 or 40 to 60, sometimes it may range to 70 3/5 screws. So the next, the other screws, it can be either in vertical or a bit deviated in order to have a long trajectory. The next one is SI plating. Sacroiliac fixation, ideally, is good to use a SI screw, that means C-arm. So in this case, if you don't have C-arm, what you do is, the first thing, see your CT or X-ray whether there is a fracture on the ala of the sacrum or not. If there is a fracture, it's not a proper place to put the screws. So if it is intact, then the next step in your approach with lateral window, first find your SI joint, then you elevate the periosteum from the ala. So here you have to be cautious about it. You shouldn't damage the L5 nerve root. So you have to push all the way, the whole periosteum together. How much we have to go medial, like a finger bridge and a bit a centimeter for your Homan placement. Here, like if it is too much to the edge of the ala, you may not have a good purchase. So that at least you have to have a place for 1 screw, ideally for 5 screw. If not, you can use 3/5 screws. And your Homan, when you put a bit medial to your place of the screw, and shouldn't be like aggressive, because you may break it, the ala of the sacrum. The configuration, if you have only sacroiliac disruption here, you can use orthogonal plates, like 3-hole plates. Ideally, if you have like 1 hole allow 4/5 and the other 2 3/5 screws, that will be a wonderful one if you have. If not, you can use the recon plates. So the trajectory, the direction of the screw matters. Here, the foramen of the screw, on the model, what you see, there is foramens. So you shouldn't go to there, because that is the nerve root coming through. So the trajectory is like, as you see here, you can put 1 pin into the joint, just into the sacroiliac joint, so that it should be parallel and a bit anterior, because the sacrum is like deviated anterior posteriorly. So your hand, or the drill hand, is pushing the abdomen and a bit elevated, so that you can parallel with SI joint, so that you can safely put your screw directly there. The next one is LC2 screw, especially if you have a fracture on the iliac wing. You can use 2 screws, either plating on the edge of the ilium or on the superior suprapectinal region, or you can use screws into the directly from anterior inferior iliac spine to the posterior superior iliac spine. That is a good bone in that trajectory, and you can add more on the wing of the ilium, because the medial part is not a strong bone, so that you cannot fix it there. So here, with your lateral window, you can put your malleable so that you can see directly the iliac fossa. either you can start by reducing the fracture, or you can just start by drilling, so that you can see directly when the drill is coming through the fracture site. If not, you can adjust. Once you see inside the fracture, you can reduce and you can advance proximally. The fixation of the edge of the ilium, most of the time it's good to start a bit posterior, so that you can have a good trajectory, because the proximal one is iliac wing is curved one, so that in order to access that one, you have to be a bit posterior, so that you can see directly and you can advance some of the screws. So let me discuss on some of my patients, in real patients. So this is a 32 years old male patient who got road traffic accident, and as you see on the 3D recon by the DICOM, there is opening up of the symphysis pubis and cephalic migration and posterior displacement of the sacroiliac joint, so that my fixation, I use 145 screw on the ala of the sacrum and 2 screws on the ilium, and another recomplete on the anterior pelvic ring. The anterior pelvic ring, you see on the inlet view, there is some displacement that is acceptable in the absence of the CR. So when you have this type of fracture, first open your anterior pelvic ring and apply your clamp and go to your lateral window. See the SI joint, how it is reduced. And if it is reduced, you start your fixation either from posterior or anterior. If it is not reduced, you can negotiate a bit correction of the displacement. As you see here, the screw, the first screw trajected laterally, and the other one is a bit medial, so that you will have a good fixation, and the sacral screw is just parallel to the SI joint. The next one, 45 years old male patient. He is also with a road traffic accident. He has pelvic ring fixation on 2 sites. One is a lower crescent fracture, and the other is the opening of the symphysis pubis. So here, all the same technique, just you reduce anterior one, apply your clamp, and go the lateral window. Either use, as I said before, 2 parallel screws on the edge and on the LC2 screw. But here, there is also another fracture exiting on the edge, so that I prefer longer plates holding the whole edge of the ilium, starting from the anterior inferior iliac spine towards the posterior superior inferior iliac spine. And the other plate is on the suprapectineal area. Here, you don't need to go to the SI joint, because you have some intact ilium, so that you can connect with the fractured ilium to the intact one. So the fixation is well, and the screws is crossing. That is wonderful for stability purposes, and the fracture healed without any problem. The other one, a 34 years old male patient with road traffic accident again. This is also crescent fracture dislocation with pubic rami fracture. Here, like, you can use, like, as I said before, the screw, but for the screw fixation, the intact part is not strong, so that will not be ideal one. So this patient also, as you see here, on the edge of the ala of the sacrum, there is a fracture. So that's very difficult to put a screw or a plate on the ala of the screw. So I use 1 plate on the edge of the ilium, and the other one just on the intact part of the ilium, not on the sacrum, because the sacrum is broken here. And the other fracture fixation by the suprapectineal plates. So here, one of the screw is beyond the unaffected symphysis pubis, but if you don't have the C-arm, that will happen, no problem. But the fracture healed in a good position. The next one, 18 years old female young patient. Here, like, there is also zone to sacral fracture. If you have this type of fracture, SI screw is very important. If not, you have to use posterior sacral fixation. Personally, I don't want to use posterior fixation. Even for beginners, it is not a good one, because soft tissue complication is very high in a patient who have the wound may days. So what I prefer is just, this is quadrirami with the fragments are going into the pelvis. So for future delivery process may not be a good one. So I prefer use plates all the way from right root of the acetabulum pubic rami to the left side. It may need a larger approach. You have to flex both hips in order to avoid struggle with iliopsoas muscle, but still it is doable to fix, and you allow not to weight bear the patient for 3 months, so the fracture heal in these positions. The other patient, she's 15 years old female patient also. As you see here on the iliac x-rays, the pubic, anteriorly pubic rami is broken and posteriorly the sacroiliac disruption, but the sacral ala looks good. So look, this is my trajectory. As you see here, the screw is just parallel to the SI joint, and I augment with 2 screws on the iliac wing so that it will be stable. Anteriorly, it's possible to apply X-fix, but most of the time patients are not tolerating, especially in third world. Patient may not be comfortable to also to take care of the pin side, so that may be infected. So most of the time I avoid not to use external fixators, but the fracture heal in a good position. The other one, this is a patient who have a wall fall on the pelvis, and see the 3D recon. There is a locked symphysis with pubic rami fracture and crescent fracture dislocation. So it's possible to use this one also with previous technique which I said to you, symphysis pubis plating, and then another 2 screws on the ilium. As you see here, like the 2 pubic ramis are not fixed. So if you want to fix this one, you have to advance your plate all the way up. But it's not a must to fix always the pubic rami, because as you see, the right hemipelvis is almost well constructed posteriorly, and the pubic rami is intact, so that it will control the movements. So I have many patients with this type of fixation, and they do well. The pubic rami may not displace, because posteriorly on the left side, the SI is intact, so there is no possibility to displace this fracture. So my summary, like understanding the anatomy of the pelvis is very important. And if you are comfortable with the approach, the fixation technique may not be as such difficult, even though you don't have appropriate CR in the OR. And the next thing is the pelvic model is very important during planning, during your surgery, and after the surgery for summarization, what was going on in the OR, what was the challenge, and what should be corrected in the next surgery. And the third one, very important, was in coordination of your brain with this hand and with your model. In what direction is the bone stock is there? So how I advance the screws. So this is very important technique. Okay, thank you very much for your listening for my talk. Hope it will be helpful for your day-to-day practice. And again, I would like to thank both the organizers. Thank you very much.
Great. Thank you so much, Dr. Tessema. We've got some great questions coming in through the Q&A function. Thank you for that, and please keep them coming. The first question for Dr. Tessema, if you can turn on your audio, but the first question is about SI screw placement. And the question is about, I think first the question really is asking about how to do it, whether it's safe to do SI screws without a lateral view. But I think I'll go a step back and actually ask you, if you don't have a C-arm, is it safe to try to do sacroiliac screws as the first question?
Okay, so that's a good question. In the absence of the C-arm, it is not a good way to use SI screws. That's very dangerous. There are some people they are trying, but that is too much dangerous, and the possibility to injure the nerve is very high. even for the beginners, even with the C-arm. So it's better not to try at all. I will not recommend you to use SI screws for this. About the imaging, I think if you have a pelvic injury, you need to have a CT scan at least in order to see how is the combination and whether there is involvement of the ala of the sacrum. Because if you plan to plate the sacrum, the ala should be intact. So you may not need a lateral X-ray, but in order to see that how is the trajectory, yeah, it's possible to use the CT. The CT scan is more important than the X-rays.
Great. The second part of the question really is about if you don't have a lateral C-arm image, and there's sort of the inlet and the outlet and the lateral. If you are unable to get a lateral because the patient is, in this case, is very obese, is it still? Are there any tips or tricks for how to still safely place sacroiliac screws?
Yeah, my talk is mainly on how to do fixation in pelvis in the absence of the C-arm.
Right.
So personally, I most of the time I didn't use lateral X-rays for SI screws. What I use is inlet and outlet most of the time. It's if you have like dysmorphic features of the pelvis, I try like rarely to use a lateral one. Otherwise, I'm comfortable with only with inlet and outlet views.
Great. Dr. Morshed, do you have any comments on that with your choice of inlet, outlet, or lateral views for sacroiliac screws?
Yeah, I would agree with Dr. Tassima, and I want to emphasize something he said, which is that you need that CT scan in order to even understand what you're looking for on your C-arm images. So he referred to this idea of a dysmorphic upper sacral segment. In those scenarios, the lateral image it can actually be deceiving and may not provide you the same information that you want to see. So, I definitely I would agree with those comments. I wanted to add another important point, which is a lot of the cases that Dr. Tassima showed were LC or lateral compression variant fractures. If you have that fracture entering the anterior aspect of the sacroiliac joint, that can make your fixation into the sacrum really challenging. I think that's another reason why the CT scan is very important. He also emphasized that, and I think that's very important because if you plan on plating across the SI joint in the setting of that anterior sacral crush, that's going to decrease the amount of space that you have for good screw purchase on the sacroiliac side, and you might have to think about other strategies for obtaining fixation of the posterior ring.
Great. So there's a lot of questions that are get into some advanced sort of questions about fixation strategies. There's one question that I think is really a good fundamental one, which is what's your preference regarding the order of fixation, Dr. Tassima? When do you start in the front? When do you start in the back? When do you need to do both? How do you decide where to start?
Yeah, when I have especially both side like fracture or diastasis, anterior and posterior dislocation. So in the absence of C-arm, like easily you can start either of the two. But before I fix one of them, I check either anterior or posterior. But ideally, I open anterior first, and then I try to reduce. I put my clamp and go to posterior side, that is through the lateral window. I open the sacroiliac joint, and I will check how is the reduction. So sometimes there is some rotational deformity that's very difficult to see on your clinically on the top view. So I try to reduce, and then once it is reduced anterior and posterior, I start from posterior and go anterior. But the issue is whether it is well reduced or not. That's very important part.
Can I add something to that? I think, again, understanding the injury pattern is really critical in trying to estimate how much reduction is going to be had by way of fixing the anterior pelvic ring. I think in a B-type fracture, a horizontally stable fracture with a relatively simple anterior component, you can assume an indirect reduction is going to be obtained by anatomically restoring the anterior ring. We know that most of the structural integrity of the pelvic ring is conferred by integrity of the back, right? But often with these open book patterns, or the classic one where you've got a hinge, an intact hinge in the back of the pelvis, by bringing the front of the ring back together and repairing it anatomically, you're also closing the posterior ring, right? In scenarios where you've got a C-type injury, where you have a hemipelvis that is both vertically and horizontally unstable, just fixing the front will not necessarily restore the integrity of the posterior pelvic ring.
Great questions. I have another question here that gets into a lot of issues around open pelvic fracture treatment. And before getting into the open pelvic fractures, I just want to take a step back and ask the question, Dr. Tassema, about your initial management of these high energy pelvic ring injuries. What are the things that you're doing when the patient first comes in to save their life? What are kind of the initial steps for not an open fracture, just a general pelvic ring injury?
Okay, that's a great question. So in pelvic ring injuries, especially those patients who have open pelvis, they bleed a lot. And unfortunately, in our setup, most of the time, these patients, they like, it is rarely to find like significant opening up of the pelvis. They reach into the hospital because they die on the road, because they bleed a lot. So we don't have like a good ambulance system, emergency bystander, so that they close up the pelvis. But for patients who are lucky to be around the hospital and they're brought to the hospital with like shock, the first thing we advise is just to apply pelvic sheet binder directly on the GT. Especially for simple open book, like we apply pelvic sheet on the GT and internal rotate the leg. We can tape it, the fingers together, the thumb, and applying the pelvic binder in situ. In this case, like if you have a patient with leggings discrepancy, we advise first to apply traction on the shorter side, and then when you think it is equal to the other side, just we internal rotate both legs and apply the pelvic binders. It could be appropriate garment, or it could be any bed sheet, so that you can fold it and you can apply directly on the GT. And one of the challenges, especially in our setup, is like especially patients who are coming from district, is the placement of the catheters. You know, most of these patients, they have associated urethral injuries. So because of this, they put directly on the symphysis pubis their catheter. So that's very tough job just to open that area, and infection is very high. So we always advise not to catheterize exactly on our skin incision site. So it's better to put it a bit proximal than the usual site for suprapubic cystostom.
Great. Now, to get into really the actual question, which was about open pelvic fractures associated with a pubic symphysis disruption, how do you approach that? What's your sequence to approach an open pelvic fracture?
Yeah, if you have like open fractures, and if it is associated with abdominal injury, something like that, with hemodynamic instability, immediately we will take to the OR and we'll apply emergency external fixators, so that we can manage like any intra-abdominal bleeding, and then we'll come back when the patient is well resuscitated. And if it is open, just we do the debridement at the same time, but we have to minimize the way of our exposure to the surrounding tissue, so that we keep minimal invasive techniques.
Great, great. Sam, any comments on that regarding open pelvic fracture treatment?
Yeah, I mean, I think that, and we can provide the reference. There's an article by Rout which talks about using a simple hospital bed sheet as a life-saving anti-shock sheet, and we can put the PDF up on the hub and the portal for you all to have a look at. I would completely agree with Dr. Tassima that the open injuries are life-threatening. If they make them to your hospital, often in our setting, we have a good EMS system. The binder is usually applied in the field to the patient that they're concerned about, and that can be really life-saving. If that patient happens to get to you, you in the emergency department, or your trainees or assistants can apply that as a really life-saving intervention. It closes the volume of the pelvis, will stop that retroperitoneal bleeding many times. I also would emphasize that if you see an open wound, pack it as you're putting the binder on. You can take a Curlex or theater sponge to block that bleeding, apply your binder, resuscitate the patient, and I would agree with the comments about an external fixator being a very useful tool, often a definitive tool for those kinds of injuries. You saw a lot of really nice demonstrations of open reduction with internal fixation in Dr. Tassima's presentation, but I remember that an external fixator is a great way to manage a pelvic ring injury as well. We'll talk about, hopefully in the future, some techniques for that. You can put pins in the iliac crest. You can put them through that LC2 corridor that was mentioned in the lecture, and that can be a very powerful either intermediate step to achieving stability. And often I will leave those external fixators through as definitive management.
Great. I think I'm going to take one last question, and then before we move on to the next lecture, just to stay on time, but I think it's a good one on this theme of kind of initial management and care. Dr. Tassima, do you do pre-peritoneal, do you do pelvic packing as part of your resuscitation protocol for these high energy pelvic ring injuries?
Yeah, like rarely, that I said before, like patient who have major bleeding, they didn't come because we have like less encounter with this type of patient. But if you have like they survive and arrive in the hospital, just yes.
Sam, any comments on that?
Yeah, I mean, I think this is maybe maybe not a completely irrelevant question to the setting that many of you practice in, as Dr. Tassima articulated. That these patients are if you're not seeing them within the first hour of their injury, they've probably expired already. The ones that would actually benefit from pre-peritoneal packing. I will say that in North America and Europe, it is still controversial. There are a few centers that are really committed to pelvic packing, and even if you look at their data, they've been criticized for not using it on all of their patients. I think that the controversy, and again, maybe it's a little bit of an abstraction, but it's related to those patients who are non-responders to initial resuscitation in the emergency department, whether they ought to be taken directly for pelvic packing or whether they would benefit from embolization by an interventional radiologist. Again, it may be a little bit of an academic discussion here, but could certainly, if you're interested in that question, I can certainly provide you the literature to kind of read up on it.
I would imagine that if you're in a setting where you don't have access to angiography and embolization, that it would be a relatively low resource method to control hemorrhage.
I think that's a good point, Dave. And I think if that patient happens to get to you, the technique is going to be something that I will demonstrate actually in one of the surgical videos. You'll see that it's basically the anterior intrapelvic window that's opened or via a classical kind of Phanestoel approach. And you get into the space of Retzius and work around into the retroperitoneal space and pack that off. it's important to distinguish this from a laparotomy. This is extraperitoneal. You're outside of the peritoneum itself. And the intention is to stem the retroperitoneal bleeding that is associated with these injuries. And the videos that you'll see will demonstrate the approach, should this be something that you want to try.
Fantastic. So those are all great questions. I'm sorry we haven't gotten to all of them yet. We're going to have more time for Q&A after each of the subsequent talks, and we'll try to get to as many as we can. We're going to all now move on to our next talk, which is by Dr. Hailu on acetabular fractures.
Greetings to you all. I'm Samuel Hailu from Ethiopia. I'll be talking to you about management of acetabular fractures in resource-limited settings. The focus of this talk will be on how to tackle acetabular fractures, mainly in settings where there is no CR. I will start my talk with a couple of cases that you see here. Think of what your diagnosis is in these two cases and the management options you would consider in your settings. The outline of my talk will be non-operative followed by operative management of patients with acetabular fractures in the absence of CR, and then we'll summarize my talk. For easier understanding, I have categorized non-operative considerations into a posterior wall group, a post-Coleman group, and non-posterior wall, non-post-Coleman acetabular fracture group. In patients who have posterior wall fracture, mainly this will be associated with acetabular fracture dislocations. Hence, after reduction, assessment of stability of the hip is done primarily by doing a dynamic fluoroscopic examination. But in the absence of CR, we can still rely on a reasonable alternative option, which is a measurement of the defect of the posterior wall. We can use various methods. Kitt's method is one of the reliable methods in terms of sensitivity as compared to the gold standard of the dynamic fluoroscopic examination. This patient has a 17% posterior wall defect, which is less than 20% and hence is considered a stable hip, as opposed to patients who have more than 40% who would need direct open reaction transfixation, whereas patients that lie between 20% and 40% posterior wall defect will have to undergo stress examination. So this is a case example I gave you a year out after the fracture with a well-maintained joint space with no sign of arthritis. The second category is associated post-Coleman fracture. Most of post-Coleman fractures will have what we call secondary congruence. Even though they might have medialized and cephalized head, it can be safely conserved as long as they have secondary congruence. The third category is non-posterior wall, non-post-Coleman acetabular fractures. As long as the hip joint is congruent with its relationship of the intact part of the ilium, this can be a consideration for non-operative management if the rough arc measurement lies in on average of more than 45 degrees. This is the first case that I gave you. This is a T-type acetabular fracture with obturator exit. The hip is congruent when you compare it to its relationship with the intact part of the ilium. We did ipsilateral elevation of the hemipelvis 45 degrees to get obturator oblique view of the fractured site, and contralateral side hemipelvis elevation of 45 degrees to get iliac oblique view of the fracture on the right side. This showed us this rough arc measurements, which is on average of more than 45 degrees. Hence, this was conserved with a year's outcome of a healed anterior column with still visualized posterior fracture line. However, the patient remained asymptomatic and is doing her daily living without any problem. With this, we'll proceed to the operative management And for this, we will briefly see the bony anatomy as well as the surgical anatomy in detail on the subsequent talk. And we'll discuss about the challenges that will be faced with when you are dealing with these patients and when you are managing them in the absence of CRM. And I will summarize the tips and tricks that I have learned over the years in the 10 points. So we need to understand the bony anatomy. And the importance of this bony anatomy is to be safe on our hardware placements. From the front view of the pelvis, the iliopectineal imminence that we see here is basically lying right over the acetabulum area. So this is no-no zone for the anterior part of fixation. So we should not put any sort of hardware around this area unless for specific screw corridors, but that will not be safe in the absence of CR. I strongly recommend against putting any sort of hardware in this iliopectineal imminence unless we have C-arm visualization. From the posterior side, you can look at bony anatomy, and what makes it safe on the posterior side is to use a 7-hole plate. So we can put 2 distal screws and 2 proximal screws above the acetabulum. So that will keep us away from the joints. The challenges that will be faced with reduction assessment is not direct unless we have done a surgical hip dislocation. Screw trajectory is not again visualized well. We'll discuss on how we can try to avoid this sort of complications. The other thing is visualization of the body corridors will not be as easy, nor is assessment of stability. We will adopt our management option in the absence of CRM, keeping these challenges in mind. So this is the second case that I presented to you earlier. The first thing is to understand the fracture pattern. We need to recognize and understand the classification as it guides our management and it gives us a good clue on how to tackle these specific fracture patterns. If we don't have a proper imaging, one of the things that could help us is to use the X-ray that we have and get appropriate due date views in the traditionally described technique. So this is the AP view, which shows disruption of the iliopectineal and ilioscaal line. And if you closely look into the supraacetabular area, you can see a fracture line going on the supraacetabular region as well. But the head seems reasonably positioned below the dome, and the iliac oblique shows the posterior column fracture. However, when you do the obturator oblique view, what it shows is the head is not actually positioned below the dome. So in a way, this due date view is acting as a stress exam, which is showing that the head is actually medialized into the medial floor. Whenever possible, we should get a scan. Make sure to visualize the fractures using a bone window of the axial, the coronal, as well as sagittal constructions. In the axial slice, you can note that there is no exit of the fracture on the iliac crest region. On the coronal slice, you can appreciate the separate articular piece with the gap of the fracture in the supraacetabular fracture line. In the sagittal reconstruction, you can appreciate the gap, which is much more than 3 millimeters. So this is a 3D reconstruction. However, we should not really rely on 3D to understand the articular fracture area, and we should try to get deeper understanding of the fracture using the axial, the sagittal, and the coronal reconstructions. The second point we'll talk is on planning of our reduction technique as well as fixation technique. For this, I use a dry erase pelvis model with a whiteboard erasable marker. So this is a drawing of our fracture, which is an incomplete associated post-column fracture with the plan of doing suprapectineal and infrapectineal plate are laid along with LC2 screw. So this is the articular side fracture visualization in planning. This is an example of a T-type acetabulum fracture with articular separate piece. As you see, the posterior column is high variant, whereas the anterior column is a low variant, which is below the ilopectineal eminence. So for this specific patient, the plan was to just fix the posterior side and to leave the anterior alone, as it is way below the roof arc measurement that we discussed. So it's not going to affect the stability of the hip joint in general. So for this, the plan was to do a lag screw, which typically I use a 4.5 screw. We can also use a 3.5 screw with neutralization plate, which is over contoured on the fracture side to compress the opposite side of the column. Part of the planning is contouring. For beginners, what I strongly recommend is to actually pre-contour your plates before the day of the surgery and then get it sterilized. The 3 steps of contouring are curving a plate, bending it to fit into the bony architecture of the acetabulum, and twisting it to make sure that the flat part of the plate is actually lying directly on the bone. The third point is to choose the appropriate position depending on the settings that we have. For posterior approach in general, I use lateral position. As these fractures are following a high energy injury, the chance that patients have other concomitant injuries is high. And prone positioning is a demanding position in terms of equipment. Also, resuscitation and stabilization of patients is not always that easy. And also in the absence of C-arm, it makes it much more easier to convert to a surgical hip dislocation when the need arises. And hence, I prefer to use a lateral approach for most of my posterior approach. The fourth point is to choose the optimal approach and exposure for the specific fracture. So the general indication for a posterior approach would be the ones that I highlighted with green, i.e. posterior wall, posterior column, posterior column fracture, transverse plus posterior wall. Majority of the T-types and transverse fractures can be managed from the back, and the other fractures will primarily be managed from the front, but depending on the fracture displacement and duration from the injury, we might also opt for a combined approach and or other extensile exposures. So surgical hip dislocation is the other approach that you might consider in settings like ours, where it makes it easier to see the articular surface and access the anterior column of a fracture involving both columns. The fifth point is direct visualization of the fracture site and the joint surface by distracting the joint with traction being applied on the ankle as well as on lateral traction using shank spin as is done on this specific patient on the lateral trochanter area, or you can also use a hook on the greater trochanter area to distract the fracture site. So if you visualize directly the fracture site as well as joint surface, it gives us a mental picture of where the screws can safely go to stay outside the joint. The sixth point is to know your screw corridors. So these are all the available acetabulum fixation corridors. The seventh point is to drill before reducing and fixing a fracture. So as you can see, in all fractures, this is an example of a posterior wall fracture where we are pre-drilling the fracture site and the drill bit is exiting on the extra-articular part of the fracture. So this will make it easier to be sure that our screw is going extra-articular. So we will mark the entry point and then reduce it with pelvic pusher, and then we can drill it in lag mode. So for example, this one is a 2.7 drill bit. we will reduce it, and then we will use a 2O wire to hold it provisionally reduced, and then we will lag it with a 2/7 screw. So the 8th point is reduction in provisional fixation. K-wire is one of the tools. Pelvic pusher or ball spike pusher is one of the easily available reduction tools that we can use for this sort of fractures. The other reduction in provisional fixation tools that we can use include young blues along with the shank spin on the ischio-pubic segment, which makes it easier for rotation purpose. We can also use the Farabuff clamp. The angled Mata clamp is quite helpful in reduction of the anterior column, both in a T-type acetabulum fracture or in a transverse acetabulum fracture. So this can go from the lesser trochanter area or from the greater, this clamp can go from the lesser sciatic notch or the greater sciatic notch. So fixation-wise, our armamentarium starts from a 3-hole 1/3 tubular plate where we can cut the ends of the 3rd hole to create hook that can be buried into the small piece of a posterior wall, and we can use this as a fixation technique for quite small posterior wall fractures. In a bigger posterior fracture like this one, we can actually first reduce it, lag it, and then put a 6-hole or a 7-hole plate to reduce and fix it from the back. In a patient that has a medialized fracture, we can use a suprapectineal and infrapectineal plate like this one from stop-out window. And when the need arises, we can also use the first window like this case. The other case of a medialized and cephalized head is this comminuted anterior column quadrilateral plate fracture. So in this specific patient where the anterior column and the quadrilateral plate is quite comminuted, one of the things that we add in addition to the suprapectineal and infrapectineal plate is this sort of figure 7 configuration plate using a 3rd tubular plate. In specific cases like this one, you can also use the same plate and make a proximal bend to hold it into the supraacetabular area by a single screw, and then the plate of the suprapectineal and infrapectineal goes over the plate as a buttressing and holds everything nicely stable. So in a variant fractures like this one, screw-along configuration might hold it using iliac crest screw, LC2 screw, and supraacetabular screw. So if you think of plating this specific fracture, it will not be straightforward, as you can see. Hence, screw-along is the best option after appropriate reduction of this fracture. In a fracture like this one, where the quadrilateral fracture alone is broken and the head is medialized, we just need to do appropriate reduction and buttress the medial wall with a single 10-hole plate, like the way you see it here. So my last tip is not to hesitate to take patients back to the OR. As we are doing this in less than ideal setting, the thing that I advise here is, so be vigilant in the post-op image that you get. I strongly recommend you to get at least 3 views, but if whenever possible to get 5 views, that will give you a good understanding of where your screws are. In general, if you see a single screw extra-articular, it is going to be extra-articular. So that's the rule of thumb. So you just need to get a 1 view that shows you the screw in question is extra-articular to be sure that all the hardware that you are worried about are extra-articular. So this is one of our associated post-acetabular fractures that was managed without CR. And now, because we don't have CR, we're not able to see the length of the screw. The screw that we used is not the same size that we measured. And so now we had to take the patient back to the OR. So instead of opening the first window, we just went from the bottom side and cut the distal end of the screw. So this is the other patient with associated vascular acetabular fracture for whom we did a front side fixation. However, we are not able to get appropriate reduction and fixation. I realized that the posterior aspect is opened up. So we took him back to the OR and did the posterior fixation. In summary, proper fracture understanding and evaluation is key to appropriate management of acetabular fractures. Planning is the solution to avoid complications. Appropriate position and approach is the way forward. It's always safe to visualize the fracture and joints in order to remain extra-articular. Drill fractures before you reduce them. That way you will realize that you will remain intraosseous along your screw fixation pathway. Provisional and definitive fixations should be planned ahead of time and have a definitive fixation in mind before going to the OR. And don't hesitate to take patients back to the OR when the need arises. Thank you.
Hyder, that was a fantastic talk. We have a lot of great questions. And thank you. Please, I mentioned it in the chat, but please upvote questions that you would like to see answered as well. So even if you don't have a question yourself, take a look at the Q&A and hit the thumbs up if it's a question that you're really interested in. So the one that got the most thumbs up so far is really a two-part question. And the question, Sammy, is about associated femoral neck fractures and then elderly acetabular fractures. I think I'd like to break it into two separate questions. So the first question to you is, in elderly acetabular fractures, what are some of the unique considerations in those patients?
Thanks, Dave. So the typical fracture pattern that we see in the elderly will be the one that you have seen with the anterior comminution. So in those patients, the kind of plate configuration that I showed you with the third tubular plate being used along with the suprapectineal and infrapectineal plate, and try to make the screws as long as possible. And that will be a kind of configuration that would be useful in the elderly. Obviously, if you have a locking plate, you might consider it, but this will solve the buttressing by buttressing the fracture and lateralizing it. And when a neck fracture is associated with it, so we might have to do acute total hip replacement or hemiarthroplasty, depending on the age group. So it's not going to be a straightforward case, but in the elderly, that's a well-described technique, and that can be done at the same time. So if you opt for a total hip replacement at the same time, the type of shell that you should use should be a multi-hole trabecular metal cap shell, and try to use multiple screws to improve your fixation.
Great. Sam, any other comments on elderly acetabular fractures, surgical indications, and then?
Yeah, I think it's an area that is of great controversy right now. This year at the annual meeting of the Orthopedic Trauma Association, the preliminary results were presented from a study from the United Kingdom, which was a 3-arm clinical trial that was comparing non-operative to fixation versus fixing and replacing. Obviously, it was small numbers to date. This is a trial that'll probably take another year or two to finish, to try to get at this really difficult question. Otherwise, I would agree with what Dr. Hailu said. It's clearly, if you've got an osteoporotic acetabular fracture associated with a femoral neck fracture, that's going to be some kind of fixation and arthroplasty.
Great. What about kind of question was re-asked just specifically about femoral neck fractures associated with acetabular fracture. If you have a younger patient who's not probably an ideal candidate for arthroplasty, Sammy, what would be your approach in that situation in terms of sequencing your treatment?
Yeah, so I have had a couple of patients with associated both column and femoral neck fracture at the same time. So the typical approach that I use is, if I use the first window, I just extend it into a Smith pit. So it will be a sort of iliofemoral approach. So most of the things can be done with just that window, and sometimes you might need a stopper window for the approach wise. And in the couple of cases that I had, the head was actually medial and it was fractured and it was medialized. So the first thing that I had to do was open the fracture up, like the fracture gap, and retrieve the head before doing other things. So it is challenging, but I found iliofemoral approach maybe sometimes. I guess I do it more often now. I do osteotomy of anterior superior spine, especially when the superior part of the ilium is intact. I do use osteotomy of the anterior superior spine to have more exposure, and gives a good enough exposure for both fractures. And for the screw placements, if it is done exposed, in the absence of C-arm, what I typically do is I get the 3 wires up to the neck of the fracture and visualize it as the screws, as the wires exit the fracture site, and then back it up until the fracture site, reduce the neck, and then advance it and hold the fracture reduced, and then switch it to a screw. So in terms of screw positioning, it is easier once you have the exposure very well.
Great. And we're going to show some approach videos here shortly that are going to hopefully show some of these techniques at least. Maybe the last question, we're just getting a little bit tight on time, but one last question before moving to the approaches is about, it's a 3-part question. I'm going to focus on the last question, which is fixing the quadrilateral surface. Particularly without C-arm. You showed some, I think, really great techniques using additional plates through an interpelvic approach. Can you talk a little bit about dealing with the quadrilateral surface in the absence of C-arm?
Yeah, so quadrilateral surface in the absence of C-arm, I think the 2 examples that I showed are the classic things that I would do. So you can also use a long distal radius T plate in the same manner, with the T being on the quadrilateral surface side. So what you can do is you can bring the T part here on the quadrilateral surface, and the one end of the other plate of the distal radius plate can go and put a screw here. But really the key plate is the infrapectineal plate that goes below the iliopectineal line that we see. That is the key plate that brings everything lateralized. And one of the things that we should do is, put a shunt spin on the lateral part of the trochanter to keep it lateralized, and buttress this with the infrapectineal plate. And when it is comminuted, a simple cervitular plate, or you can also use actually, the recon plate that you have, and buttress it, and adding obviously the suprapectineal plate makes your fixation strong enough.
Great. Still lots of good questions. I think what we should do, because a lot of the answers are discussing a lot of these approaches, is we can show our surgical approach videos that Dr. Morshed has prepared, and then we'll have more time for additional questions at that point. So.
The Coker-Langenbach approach. The Coker-Langenbach is the workhorse posterior approach for acetabular surgery. You can see here shaded the areas that are going to be under direct visualization through this approach. The black shaded area here is the posterior wall. You can see in red the arborization of the superior gluteal artery, and in blue there we have the course of the sciatic nerve. And this is the location that you would be putting a plate for fixation. So on a cadaveric specimen, you can see we've marked out the posterior superior iliac spine, the tip of the greater trochanter. And this approach is oriented in a way in order to allow for the surgical approach, which typically is about 2/3 proximal and 1/3 below the tip of the greater trochanter in line with the femoral shaft. I like to start this approach distally in order to properly identify the tip of the greater trochanter before making my angle up towards the posterior superior iliac spine. Particularly in very obese patients, this is a great way to properly orient your incision. You can see here that I'm incising the fascia lata. This allows me to palpate the tip of the greater trochanter. We can identify this by rolling the leg, which will in turn identify the proper location for redirecting the angle of our proximal limb of the incision. Skin and subcutaneous fat are divided in line with the skin incision, identifying the fascia over the gluteus maximus muscle. From the location that we angle our incision, we turn in line with the fibers of the gluteus maximus, splitting the muscle in line with its fibers. Below the gluteus maximus, we will see the trochanteric bursa, which we will remove in order to better visualize the short external rotators of the hip. Below us now we see the gluteus medius muscle, and we can separate this from the underlying minimus, which is typically badly injured with particularly posterior wall acetabular fractures. And we are going to look for the piriformis tendon, which is going to be inserting on the posterior superior aspect of the greater trochanter. After we've identified and palpated it, we're going to identify a location for cutting of this tendon. We stay 10 or more millimeters away from the back of the greater trochanter in order to avoid injury to the blood supply to the femoral neck. Next, we cut the tendon and tag it. We'll be careful not to dissect sharply too much more medially, as we're going to be coming into close proximity to the sciatic nerve, which we'll see unveiled here as we elevate the piriformis. Here you can see it reflected, and underlying it, the sciatic nerve. Next, we move in a caudal fashion and identify the superior and inferior gemellus on either side of the obturator internus tendon. The obturator internus tends to be a more easily identified tendon in this location. The gemelli tend to have a muscular presentation all the way to the back of the greater trochanter. These are elevated medially, sending us to the lesser sciatic notch. This dissection is completed with a cob, Here you can see the sciatic nerve exposed with elevation of the piriformis. The obturator internus tendon in turn can be elevated, protecting the sciatic nerve, allowing us ample room and a pathway for identifying a location for a retractor to better expose the posterior column. We call this the bent knee retractor because it's important to bend the knee in order to take tension off the sciatic nerve. Here are your retractors for visualization of the wall and column. As you can see here, a great view of both posterior wall and posterior column. We can see superiorly all the way to the proximal aspect of the greater sciatic notch, the lesser sciatic notch which houses the retractor. Caudally we can see the ischium, posterior hip capsule, and posterior wall, which can be palpated. Of course, in the setting of a fracture, it's going to be more easily identifiable, that posterior wall fracture. We can also use a cob or elevator to carefully dissect around and into the greater sciatic notch in order to palpate the quadrilateral surface should we need to access that location for clamp application. One should be mindful of the trajectory of the superior gluteal artery, which leaves the greater sciatic notch and arborizes, feeding the gluteal musculature, and can be easily injured in the setting of a high posterior column fracture or due to iatrogenic manipulation. Here, we have a simulated posterior wall acetabular fracture with underlying femoral head. When cleaning this fracture, one will want to make sure to not detach, as we have here, the joint capsule. This is done to show the proximity of your plate application to the peripheral posterior wall. And this is a repair of both the piriformis tendons and obturator internus tendon during our closing portion of the procedure. If you use an angled incision through fascia, as I have here, this will assist in identification of a corner at which you can begin to close your fascia lata.
I think we've already got a few questions coming in about this here. Actually, the first question I'm going to ask, because, and perhaps Dr. Hailu can join us as well for this question, is just about positioning for the Coker-Langenbach approach. Dr. Hailu talked about positioning lateral for a Coker-Langenbach approach. Dr. Morshed, obviously this video is in prone position. First, Dr. Morshed, do you want to just talk a little bit about why you like the prone position for this particular approach?
Yeah, the prone position is my position of choice for doing the KL. There are a couple of reasons for that. One is that it puts gravity on your side. So often you have instability here, either posteriorly or medially, which is neutralized if not countered by the force of gravity. So I find that in a lateral approach, while the retraction is somewhat more straightforward, it's a little bit easier on your surgical assistants when you're in a lateral position. It often necessitates the use of a Schanz pin in the proximal femur to pull the femur or the femoral head out of the true pelvis. I find that in a prone position, gravity drops the femoral head back into a more native position. So that's one of several reasons. I'll tell you that the times when I don't use a prone position are the odd fracture that has a large portion of either the posterior wall and or the posterior column incarcerated in the joint. with the femoral head still out and irreducible. In those scenarios where you're going to be having to manipulate the lower extremity in order to clear those contents out and get the femoral head back in, I think a lateral approach is beneficial because you can flex the hip as part of the reduction maneuver. But that, for me, is less than, way less than 5% of the time. So that's why I'm typically going prone. I'll add one more point to that, which is that I'll often add some fixation to the anterior column, possibly in a percutaneous way. So I will, for example, a transverse fracture with an associated posterior wall, or a T-type fracture that I choose to address from the back. Well, I still am going to need to address or fix the anterior column if I can properly reduce it from the back. The prone position makes imaging for placement of a percutaneous anterior column screw much more straightforward in my case.
Thanks, Tom. Dr. Hailu, same to you now. I know you mentioned using the lateral position. Can you talk about why you like positioning in lateral?
Yeah, so the two occasions that I don't use the lateral approach, lateral position, are in anterior, if I am aiming at fixing the anterior column in a transverse or T-type using C-arm for imaging, and if I have a bilateral acetabulum that I'm doing at the same time, I just do it prone. Other than that, most of the time where I don't have C-arm, I prefer a lateral position. Mainly, I might change into a surgical hip dislocation for irreducible hips, or for accessing the anterior column and putting screw for the anterior column side without C-arm, and I can have a direct visualization of the anterior column. And the classically described issue with lateral approach is the gravity is pushing your ilioischopubic segment of a transverse or a T-type fracture pattern. But if you apply gentle traction through, be it on a shunt spin or a hook through the piriformis fossa, you can really get away with most of the fractures. And in general, most of these injuries are high energy injuries with concomitant injury, and anesthesia related complications, prone position complications can be minimized in limited resources in my mind, I think.
Great. Yeah, I think it's just a great illustration that there are, great arguments for both of those ways of positioning patients for doing the surgical approach. There's one other question that I want to do before going back onto the video for the ilioinguinal, which was about how to handle the gluteus minimus muscle. Dr. Morshed, when the gluteus minimus is really traumatized, do you think it benefits to remove that muscle, or how do you handle that?
Yeah, it's a good question. I mean, if you look at when I was learning pelvic and acetabular surgery, my mentor really emphasized taking it out if it looked at all beaten up. And it's honestly, it's hard to do this surgery without doing some amount of elevation manipulation and further damaging the minimus. And the idea behind taking it out is that it is a heterotopic ossification generator when it is injured, which invariably is, and that by removing it, you lessen the risk of heterotopic ossification. I would say that, I typically take it out either because it's injured or because I need further exposure. In either case, if at the end of the operation that muscle looks badly injured, I think that it's very unlikely to add to the function of the hip. And heterotopic ossification, as you know, is a really devastating postoperative complication that can lead to tremendous stiffness and immobility. So yes, the answer is I'm typically removing some part or all of that muscle.
Great. So I think we're going to give it another try on our ilioinguinal video. I hope we can play it because I think it's a really good demonstration of this approach.
Dissection to demonstrate this approach. I've marked out our landmarks, including the symphysis pubis and the iliac crest, the anterior superior iliac spine. It's important to get a sense of where midline is as well. On this Sawbones model, you can see demonstrated with 3 different colors the visualization that you will see through the anterior intrapelvic window, the lateral window marked in red, and the middle window that you can see shaded in blue. We begin the approach with the lateral window. The incision courses over the iliac crest approximately a finger breadth above. We cut through skin and subcutaneous fat with cautery, dissecting down to the insertion of the external oblique as it inserts onto the outer aspect of the iliac crest. Here you can see I use my finger to palpate that edge, and now I'm taking the external oblique, internal oblique, and transversus abdominis conjoint insertion on the iliac crest off in a single sleeve. This patient has an associated both column acetabular fracture with a high anterior column exit point on the iliac crest that you'll see here in a moment. As the fracture comes into view, we can see a little bit more bleeding here. We're turning over and we're extending this dissection onto the inner table of the ilium, releasing the iliacus as we do so. Here you can encounter bleeding often through bony channels. We've dried the inner table of the ilium and packed with a lap. A retractor allows improved visualization of the fracture that you can see below my left index finger. And now we're going to use malleables to dissect medially towards the SI joint. It's important to remember to flex the knee and hip in order to relax the iliacus in order to improve exposure. Here you can see the SI joint, which is the medial extent of this exposure. If you pass beyond the SI joint, you're likely to encounter the L5 nerve root as demonstrated in this cadaveric specimen. After the lateral window is developed, I move over to develop the anterior intrapelvic window. This is a modification of Letournel's original medial window. You can see the decussation of fibers of the anterior abdominal wall as we look for midline. In this specimen, you can palpate this. In a small incision will allow one to pass a finger or malleable retractor into the space of Retzius. After we've identified midline, we will continue to split the rectus fascia between the 2 heads of the rectus abdominis in order to allow for improved mobilization. Now we're looking at the inside of the pubic symphysis. Improved exposure can be achieved by relaxing the insertion of the rectus abdominis on the pubic body. We've passed a Hohmann retractor lateral to the pubic tubercle in order to improve visualization. If you're treating an anterior pelvic ring injury, you may want to expose in a similar fashion on both sides. And this is just an example of clamp application and plate application for plating across the pubic symphysis. Should this be your desired plan for treating a pelvic ring injury. Now we course lateral, dissecting along the pelvic brim, beyond and into the space of Retzius, and we're going to identify in this location additional structures of importance, including the connection between the internal and external iliac arteries called the corona mortis, our obturator nerve and vessels, and our iliac vessels laterally. This is a demonstration here showing the connection, again, between the internal and external iliac arteries by way of a communicating artery. This artery needs to be ligated in order to improve your exposure to the intrapelvic surface and true pelvis. Now you can dissect down the quadrilateral surface towards the iliac spine. This is a video from live surgery, again demonstrating the approach that we just demonstrated on a cadaver. We're in the space of Retzius. You can see the bladder. We're going to be relaxing the rectus abdominis on the operative side. Again, this is not a cutting of the rectus insertion, but rather a relaxing of it as we elevate it off of its insertion onto the pubic body. This will allow us to dissect laterally along the pelvic brim using an elevator here to identify the pubic tubercle, and we pass a Hohmann over it in order to better expose that aspect of the pelvis. Here we're going to seek out, and again remember the importance of flexion of the knee in order to relax structures passing over the pelvic brim. We're going to be identifying as we dissect laterally that communicating vessel, the corona mortis. Here you can see it's a large structure and it will be mobilized and ligated, and you can do this with suture ligatures or vessel ties or a clamp. And as I mentioned, this needs to be ligated in order to continue to dissect along the intrapelvic surface. Now we can continue to dissect laterally over the pelvic brim and looking into the true pelvis. It's important to mobilize the iliopectineal fascia, which we'll have an improved visualization of through the middle window. And now you can see that we are at the site of our fracture. Artery and vein behind a retractor here at 12 o'clock, and we are dissecting along the quadrilateral surface back towards the sacroiliac joint through this anterior intrapelvic approach. Finally, the middle window. We connect the two incisions that we've made thus far, and we are seeking the insertion of the external oblique onto the inguinal ligament, as you can see here. We incise the external oblique fascia first. Sometimes you'll see some muscle fibers of the internal oblique here as well. And we are getting into the inguinal canal. My preference is to leave the inguinal ligament and the muscles of the anterior abdominal wall attached to the anterior superior iliac spine, although exposure can be improved either through an ASIS osteotomy or soft tissue dissection with later repair. We're mobilizing the contents of the inguinal canal here. You will encounter the ilioinguinal nerve overlying the spermatic cord, Now I've identified the floor of the inguinal canal, and through this I will dissect out the iliopsoas muscle overlying femoral nerve, and as you course medial from that, the iliopectineal fascia. I like to begin this approach laterally, starting over the iliopsoas and the femoral nerve, as this is a safer plane of dissection than traveling deep right over the femoral artery and vein. You can see here now that I've got the iliopectineal fascia, again separating the two compartments here, the vascular compartment from the neuromuscular compartment. This is an important structure to identify and mobilize so as to improve your exposure. The middle window also offers us an opportunity for clamp application and implant application, and allows excellent visualization of the low anterior column and anterior wall of the acetabulum. Here again we can see the muscle and femoral nerve overlying it and the iliopectineal fascia. This structure connects the inguinal ligament all the way back. It is an investing fascia of the iliopsoas and will course along the pelvic brim all the way to the anterior aspect of the sacroiliac joint, and it can be safely visualized and released through this middle window. Here you can see the iliopectineal eminence, low aspect of the anterior column, and anterior wall of the acetabulum. Again, demonstrated schematically on this model. These windows are all closed in a layered fashion. We close both the floor and the roof of the inguinal canal, the anterior intrapelvic window, and the fascia of the external oblique over the ilium.
Great. Thank you for bearing with us through some of the technical difficulties, but hopefully that approach was useful for you to see. We've got a lot of questions about the different approaches. I think, why don't we start with a question about both column acetabular fractures. I think it's can be confusing at first, the Coker-Langenbach for posterior and the ilioinguinal for anterior column involvement, but when you have a both column fracture, what's the ideal approach and what's the ideal sequence? Sam, do you want to take that one?
Yeah, it's a good question. First of all, I'd say that if you're early in your learning curve in repairing acetabular fractures, the associated both column may not be the first one that you want to try an anterior approach on. You might want to get started with this approach on a more straightforward pattern, like an anterior column or simple anterior column posterior hemitransverse. The patient that I was operating on in the video had a very complicated associated both column acetabular fracture, and I ended up using two approaches on that patient because I was unable to restore or reduce the caudal posterior column, and there was just too much comminution through the quadrilateral surface to be able to access and manipulate it from the front. That is the minority of cases. I would say that 90% of the associated both column acetabular fractures I treat through an anterior approach alone, using the modified ilioinguinal that I demonstrated here. You know, the question always comes up, well, what about the posterior wall? There's a posterior wall fracture there. You don't really reduce that, and you know, posterior wall fractures are, you know, often unstable, and I think it's important to recognize it, even important to stress test it after you've repaired all, you know, the anterior and posterior column components of the associated both column. But that anterior or that posterior wall fracture that we often see with an ABC or an associated both column is more of a bending wedge type fracture. It's less of push off wall that gets knocked off as the head subluxates or dislocates posteriorly, and more of a bending wedge of the lateral aspect of the acetabulum as the femoral head intrudes into the true pelvis. And so it's often stable by way of soft tissue attachments, particularly the superior and inferior labrum. So again, I'm always starting in the front, and rarely do I require a secondary approach for repairing the associated both column.
In terms of your sequence, in terms of treating the columns, you would start with the anterior column.
Yeah, I do. I follow Letournel's guidance, which was starting with manipulation and reduction of the anterior column to the intact ilium. That's really creating the foundation upon which to build everything back. And a lot of that reduction is done by way of that lateral window and a plate that buttresses that anterior column fracture down and restores its location, so that we can build upon it over the sequence. So we start with the anterior column reduction, then we will address the posterior column and the medialization of the quadrilateral surface by way of that anterior intrapelvic window.
Great. There are a couple questions about the STAPA approach. One of them is about dealing with that corona mortis, that anastomosis that you showed in the video, and how to deal with bleeding from that area. And I want to hear from you, Sam, and then I also want to hear from Sammy about this question. But why don't we start with you, Sam? How do you deal with bleeding from the corona mortis?
Yeah. First of all, I'll tell you that the corona, in some way, whether it's an artery and a vein or a vein alone, I see some remnant of that in almost every fracture, except maybe the most destroyed ones where it might have been lacerated or disrupted as part of the injury pattern. It's always there. You need to look for it. Frankly, I think that the corona mortis is less of a problem in terms of intraoperative bleeding for me than either the venous plexus, which sits in front of the sacrum or the SI joint, which is much more difficult to access, or the superior gluteal artery and vein as they pass through the greater sciatic notch. Those for me are more difficult and scary to handle. The corona mortis sounds very scary. It's the crown of death or whatever, but it's I think if you approach it the way that we demonstrated in this video and ligate it, you can usually stay out of trouble. And even if you do get into it, the two ends of it are not so far back in the true pelvis that they're difficult to access. The other source of bleeding that I think one needs to really be careful about is the femoral vein. As you look through the STAPA window, that retractor that I had up at 12 o'clock in the video, if you use a retractor that's a little too thin or a little too sharp, it's sitting right on the femoral vein. And I've seen that vessel injured many times. It's one of the reasons that I like to develop and release in its entirety the iliopectineal fascia by way of the middle window, which a lot of people don't use anymore. Many surgeons have gone to just the lateral window and an anterior intrapelvic window. I still like to really take out that sharp edge of iliopectineal fascia from the inguinal ligament all the way back to the SI joint. I just think I can do that more safely by way of a middle window. And you need to be careful. That's a vessel that can bleed a lot very quickly. It is reparable if you have some small monofilament suture. I'll usually use something between a 5 or a 6/0 Prolene or nylon stitch to close that vessel. You can usually stop the bleeding just with manual pressure and visualize that area of the vessel that's been disrupted for repair.
Thanks, Sam. And Sam, I just wanted to get your input, and maybe to expand the question, just to ask, how do you if you're in a lower resource setting doing these approaches they're big approaches, there's potentially a lot of bleeding. Do you have any tips or recommendations on how to be safe? I mean, what do you do when you encounter bleeding in these situations?
Yeah, so bleeding from the coronal mortis. So we don't have vascular clips that you showed on the video. So what I use is silk, a number 1 or a number 2 silk, and just 2 knots will hold it, tight enough, and it doesn't slip as the other sutures. And then I try to cut it more close to the external vein side than the obturator end. And if anything happens, I can access the proximal side as opposed to the posterior side. And then, sometimes, it does bleed. And when it does, just simple packing will really stop it. It's not that big of a deal. But I have had the femoral vein bleeding once. And one of the retractors, I think the resident was having a hard time holding it there. So at some point, basically, forcefully retracted it. And so it was actually in the bifurcation as part of the internal and external vein. So I had the vascular surgeon to repair that. And I also had bleeding from greater sciatic notch area, basically the superior gluteal artery, and that took quite some time to get it to stop. But packing it and waiting there for more than 10 minutes, and then trying to visualize it. And the classically described way to stop it from bleeding is finish your surgery after packing and then get angio and do that. But we don't have that. But I have had that once. And the other bleeding I had to call a vascular surgeon is fracture on the basically it was associated post-column fracture on the iliopectineal eminence area. There was comminution, and one of the pieces was actually into the artery, and it was actually perforating the artery. So from the 3D reconstruction, we were able to see that happening. We're ready for it. The moment we mobilize the fracture, that basically bled, but where the vascular set and vascular surgeon repaired it. These are the bleedings that I remember.
That's great, Sammy. I agree with those comments. And I will say that probably the most common source of bleeding that you're going to see in these operations is just bony bleeding. The pelvis is a very vascular bone, and you will see often, to your dismay, that the more you manipulate fragments and clean them out, the more the bleeding comes. Because what happens is, especially if you're getting to these cases late, there's a lot of clot that forms to stem that bleeding. And what we do as surgeons is we go in there and we clean up all the blood clots. And as soon as you do that, it's going to start bleeding again. And so one thing you might want to consider is really making sure that your exposure is complete before you start cleaning the bony edges, because as soon as those bony edges have been cleared of hematoma, they're going to start to bleed. So you want to be able to move through your reduction sequence expeditiously, because once you've reduced the fracture, again, you've contained that bleeding. There's a nice study done by Mike Archdeacon, which asked the question, or tested this question, of whether waiting some period of time to do open reduction and internal fixation reduced the amount of bleeding that you have in treating acetabular fractures. And they actually dispelled that myth. They actually found that doing these surgeries early was just as safe from a bleeding perspective as doing them late, which was, something that, ran against what many of us had been taught when we learned to do these surgeries. And the benefit, obviously, of doing them early, and I know many of you are already struggling. I see some of these questions coming in about, malunions and, partial unions and cases that are coming in late. You want to do them earlier because it's much easier to manipulate fragments and obtain a reduction. My recommendation to you is to familiarize yourself with this anatomy, watch our videos, watch as many videos out there as you can, practice, start with easier, less displaced fractures in healthier patients until you really familiarize yourself with this anatomy before you start taking on some of the more challenging injuries.
I just, as a final closing thing, I just wanted to ask you, Sammy, in terms of, again, just being safe and recognizing there's a lot of bleeding here. You've mentioned vascular surgeons. I'm sure a lot of these patients are getting blood transfusions. I mean, would you say that these are like prerequisite things that you ought to have to be doing these big approaches, or what is the minimum you should have to be able to safely tackle some of these more complex fractures?
Yeah, I think especially when you get started, it's good to do these surgeries in a setup where there is a vascular surgeon and appropriate, blood backup. So initially, when I started doing this, I used to prepare 4 units of blood for cross-matched blood for all the acetabulum cases that are booked. We still do the same thing, but at least a blood backup and a vascular surgery when you get started, and then once you are used to the approach, as long as you are doing it in an acute setting, and if you have post-contrast CT scans, to the most part you'll be able to see the soft tissues and the blood vessels reasonably well. Just don't just look at the bone and think everything else is okay. So sometimes you might see the gash sign in slowly bleeding vessels as well. So it is, I think, a good idea to have a vascular surgeon backup. But if you don't have one, at least have a micro set, at least the needle driver and 4 or 5 Prolene or something that you can use to repair as a backup. But when you get started, try to avoid doing late presenting cases, complex cases. As some said it earlier, associated post-column fractures, just try to conserve them when you get started, and as you develop later, probably the first window and the stopper window might be much more safer than developing the middle window. But as time goes on, and you might get yourself accustomed to the anatomy better, and you might do well. But vascular surgeon backup is definitely a good thing as you get started doing this.
Great. Well, there's so many good questions, but we're a little bit over time. It's already 9 o'clock now. So I think we're going to wrap up now and just have some closing remarks from Richard Coughlin, the founder of IGOT. Thanks, everyone.
Well, greetings to everyone from the Orthopedic Trauma Institute here in San Francisco. First, I'd like to thank Gelatow, Sami, and Sam for really their outstanding, informative webinar. I'd also like to thank Dave Scher for his really exceptional hard work coordinating this effort. Special thanks to Nay and Maddie, who are coordinators behind the scenes to keep us somewhat on time. Maybe not so much today, but and also Kyle Van Oker from UCSF. IGOT, the Institute of Global Orthopedics and Traumatology, is an academic initiative here at University of California, San Francisco. And our mission has been in alignment with SIGN's mission, and we've enjoyed that relationship and partnership for well over a decade. We welcome your comments, your critiques, your feedback regarding this webinar, and also suggestions about future webinars. Please direct those through IGOT portal or SIGN's hub. So with that, I bid everyone a fond adieu, and we look forward to seeing you in the near future.